My name is Megan Carmilani. I'm with Long COVID Families. We're based in Charlotte, North Carolina in the United States. Let me share our patient experience with you. So here we have Jenna, and Jenna is 8 years old. She's a competitive dancer and she's hypermobile. One of the things we've been noticing in our support groups is that many of our children are hypermobile. Jenna's father tested positive for COVID at work, and the rest of the household was sick, but was unable to get tested. This is common with children because they were either asymptomatic or very mild, and the families did not think to test them or did not have access to a test. Everyone in the house experienced mild illness. After a few weeks, they were able to resume life. However, approximately 29 days after the initial infection, Jenna started to tell her mother she didn't feel well. Her mother kept checking her temperature, which was normal, and figured she was just trying to get out of school. Well, no, actually, Jenna had developed long COVID, and this is her journey to date. After a few weeks of symptoms, Jenna saw a pediatrician who ran routine blood work and iron levels. The test came back normal. The pediatrician said everything was fine, and she just needed more time to heal from COVID. Jenna became more and more fatigued. She stopped going to her dance lessons because she doesn't have the energy and her legs ache. 2 months after, Jenna went back to the pediatrician. However, her symptoms were so vague and seemed to come and go, the doctor was not sure what to do. So he referred her to neurology, a child psychologist, and a physical therapist. It was months before Jenna saw a specialist. In the meantime, she went to physical therapy. Jenna was able to perform the exercises during therapy, but later, she felt sick. She was dizzy when standing. The leg pain she was experiencing had decreased some, but it was still present, and she's exhausted most of the time. After 6 months, the neurologist performs an in-office exam and suggests that Jenna needs to increase salt, water, and wear compression socks, but she's not given a diagnosis or any further testing. At month 8, Jenna is no longer able to attend school full-time, and she spends most of her time at home. She now complains about forgetting things and not understanding the teachers. Her grades have suffered immensely, and she has been diagnosed with anxiety and depression. At month 10, she's able to get into a COVID clinic. There is an extremely long waiting list. Once she's there, they perform more tests. The tests come back normal, and they tell her this is new and we're still learning. Meanwhile, we have research that's recognizing these following conditions in adults, and these are some of the diagnoses adults in our groups are getting. With the same symptoms as Jenna, the condition of post-exertional malaise is being recognized. ME/CFS is getting diagnosed. Mast cell activation syndrome, or MCAS, is a common diagnosis. Orthostatic intolerance is common. So symptom management, what does work? From our population, many of whom are experiencing post-exertional malaise, activity and symptom tracking is very helpful. It helps us learn our bodies. So I have post-viral syndromes from when I was a kid. It's been 30 years. I don't have long COVID, but I do have post-exertion malaise. It's 30 years later, I still have it. The activity and symptom tracking was one of the most beneficial things I've ever done, and many of our community would agree, to learn my body and learn how to re-engage with life. Body awareness is very important. Understanding energy envelope. Heart rate monitoring was a useful tool for many of us to learn what is actually going on in our body, because we have these really strange sensations we've never experienced before. Like for many of us, it's the first time that we're experiencing tachycardia. And tachycardia, when you experience it, it feels like you're under attack, right? Like there's something going wrong in your body and alarm bells are being set off in your body, and something is really, really wrong. So then you get like the amplified sense of panic that kind of comes with that. If you understand what's happening with your body, and a heart rate monitor can help do that, it's easier for you to recognize that, okay, my heart is spiking because maybe I have POTS and I stood up. It's okay, it's going to pass. And that really helps improve quality of life. The more we know and understand about what is happening in our body. So we know PEM is not about not caused by deconditioning, but we do recognize as patients that it can cause deconditioning. The type of exercises we like are strengthening exercises, floor exercises, breathing exercises. We don't like cardio. I work out 4 to 5 times a week now. I'm also on medication and have received excellent treatment. I still struggle with cardio. We also want to learn about how to survive a crash and a flare. In the patient community, we sometimes call it an impending sense of doom, because your whole body kind of goes on alert that something is wrong. And it's really helpful to know that this is a normal part of post-viral syndromes. And that what I do personally is I simply acknowledge it's happening. And I say to myself that, it will pass, right? That my body's saying it's going into a crash. I need to take care of it. I go lie down, I put a weighted blanket on, and I wait it out. The weighted blanket helps with the nervous system quite a bit. And then the darkness of the room and everything helps. And then just calmly telling myself it's okay, I am safe. That seems to be very helpful to me. And knowing that it's going to pass is helpful to work through those crashes and kind of minimize them. Many of our people in our communities experience dysautonomia. There's lifestyle changes, medical support for that, but I want to emphasize the pushing through. We've had doctors tell our community to push through the fatigue, push through the sense of dizziness, and just want to highlight that there's actually, especially in a patient population before they have access to a tilt table test, telling people to push through, you're risking a potential fall risk. I have dysautonomia myself, I have POTS. The lack of flow and oxygen to the brain, doctors need to be aware of that and what they're actually telling patients. Many of us in the community experience pain, inflammation, and allergy, whether it's mast cell activation, fibromyalgia, small fiber neuropathy. Hypermobility is very, very common. So what's very helpful for patients is really, again, tracking your symptoms, tracking what triggers you, learning about your body is probably the most helpful thing. Understanding if you are hypermobile, understanding what that means, and how to care for your body, because the way you exercise is actually slightly different because of the way our joints move. And I will bring up, for many of us, we have a lot of pain that's rooted in trigger point knots. And what we find very beneficial is dry needling and acupuncture. And when you combine dry needling with like physical therapy, it seems to be very, very helpful for a large segment of our population. And it seems to do something to the nervous system, which I don't fully understand, but I can tell that my nervous system feels calmer. Here are our community concerns. Our doctors recommending cardio. It seems to be the primary recommendation of any long hauler when they first start seeing a doctor. It's rare that doctors are discussing the possibility of PEM, and they do not discuss the test of the CPET at all. Doctors are recommending to push through. And this is incredibly dangerous for our population without running tests. Specifically, going back to patients with MCAS, I do want to highlight that exercise and exertion is a trigger and will further activate mast cells, causing a histamine release, which may trigger dysautonomia symptoms in some patients. And that's something to be aware of. Some patients say that report that they feel relief from mast cell stabilizers and antihistamines. And once they are put on these medications, they are actually able to resume exercise. But we are still concerned about doctor recommendations to push through. What we also have is a lot of referrals to psychologists and psychiatric professionals, especially if the patient is from a marginalized community or a child. Our community does not find that helpful when it's offered in place of medical care, and that happens a lot. We are specifically concerned with the pediatric diagnosis of amplified musculoskeletal pain disorder, or AMPS. This is a controversial diagnosis, and it's sometimes described as juvenile fibromyalgia. The treatment is graded exercise therapy, cognitive behavioral therapy, and children are told to ignore their symptoms. The research surrounding this is controversial, and many academics question its validity. There is no evidence linking AMPS to COVID. There is a controversial inpatient program in several pediatric hospitals throughout the US. When we talk to adults who attended these clinics as children, they describe it as abuse. I want that to sit for a moment. They describe it as abuse. It's important to recognize that not everyone will get better. As a patient community, we'd like more focus on quality of life and less on abstract improvement. We are also going to ask that we are not shamed as patients when we don't improve, because many people do feel shamed as though they're not trying hard enough. Thank you. I appreciate the time and the opportunity to speak with you.